Remember that time you were maybe stuck at home, absolutely covered in itchy spots, feeling pretty miserable, but let's be honest, maybe secretly enjoying the extra TV time?
Oh, definitely. A classic childhood memory for so many.
Exactly. And that shared experience is what we're diving into today. Chickenpox, or varicella as it's properly known.
Hmm.
We've got a really fantastic set of information here. It's like the ultimate revision guide, breaking down, well, everything you really need to know about this super common condition.
Yeah, it covers all the bases.
Our mission today, to give you a clear, really high-yield understanding of chickenpox. Think of this as your personal study session, packed with memory aids and practical stuff that'll hopefully stick.
Sounds good. And it's interesting, isn't it? A condition so many of us just sort of went through, but it actually has some fascinating biology behind it.
Totally. So let's start with the basics. What is chickenpox?
Okay, so chickenpox, or varicella, is a highly contagious viral infection. The culprit is the varicella zoster virus, VZV for short.
BZV, got it.
And the absolute classic sign, the one everyone remembers, is that really widespread rash. You know, the incredibly itchy, fluid-filled blisters that eventually scab over.
Ugh, the itch. It's almost legendary. Okay, so VZV is the cause. You mentioned the virus name Varicella zoster. What's interesting about that?
Well, VZV is actually part of the herpesvirus family.
Oh, really?
Yeah. And what's really key about VZV is that it causes two distinct things. First, you get chickenpox. That's the primary initial infection. But then the same virus can lie dormant in your body and reactivate years later, causing shingles.
Ah, okay. So it's a two-for-one deal, sort of. How does it actually spread from person to person?
It's mainly through respiratory droplets, so, coughing, sneezing, or by direct contact with the fluid from those blisters. It's very easily spread.
Which explains why it ripped through primary schools back in the day.
Exactly. Which leads us nicely into risk factors. Who's most likely to get it or get a worse case?
Yeah, what makes someone more susceptible?
Well, the biggest risk factor is pretty straightforward. Just not being vaccinated or never having had chickenpox before. If you haven't encountered it, you're susceptible.
Makes sense.
And while we often think of it as, a mild childhood thing, it's really important to remember that infants, very young kids, and especially people with weakened immune systems, they're at a much higher risk for serious complications.
Okay, so it's not always just a mild inconvenience. Let's dig into the pathophysiology then. How does the virus actually work inside the body?
Right. So VZV usually gets in through your respiratory system. You breathe it in.
Okay.
Then it starts multiplying in the lining of your airways, the mucosa. From there, it moves into the lymphatic system, kind of like the body's internal highway for immune cells.
And then
Then it gets into the bloodstream. That's called viremia. This allows it to spread throughout the body, a systemic infection. And that's what triggers the characteristic rash.
the spots appear everywhere.
Pretty much. But here's the really clever, or perhaps slightly sinister part. Even after you recover from chickenpox, the VZV isn't totally gone.
The latency thing you mentioned.
Exactly. It sits up shop, basically goes dormant, establishing a lifelong presence in nerve clusters called sensory ganglia, often near the spinal cord.
And that's the reservoir for shingles later on.
Precisely. It can reactivate under certain conditions like stress or waning immunity and travel down the nerve to cause that painful shingles rash.
Fascinating. Okay, so someone comes in with a spotty rash. It looks like chickenpox, but are there other things it could be? What's the differential diagnosis?
That's a really important clinical question because, yes, other things can sometimes look similar.
Like what?
Well, you might think about generalized herpes simplex or even widespread shingles itself, though that's less common than the typical shingles pattern.
Okay.
Then there are skin conditions like dermatitis herpetiformis, which is linked to coeliac disease, or impetigo, which is a bacterial infection. Even things like gut-taint psoriasis, other viral rashes.
Contact dermatitis.
Yeah, contact dermatitis. Or even severe reactions like Stevens-Johnson syndrome, though they usually have other distinguishing features.
So how do you tell it apart, especially from shingles?
The key difference with shingles is usually the distribution. Shingles typically sticks to one or maybe adjacent dermatomes, that specific area of skin supplied by a single nerve root. It's usually quite localized, often like a band on one side of the body. Chickenpox, on the other hand, is typically widespread, all over the body, spots in different stages.
Right, that centrifugal spread we talked about. Okay, let's talk numbers. How common is chickenpox? What's the epidemiology look like, say, in the UK?
Well, in the UK, we traditionally saw outbreaks cyclically, maybe every 3 to 4 years, something like that, though patterns can change.
And before the vaccine?
Oh, pre-vaccine, almost everyone got it in childhood. It was just expected.
Yeah, I remember that. What about immunity now?
Data from England and Wales shows that over 90% of people over 15 are immune, meaning they have IgG antibodies, likely from past infection.
Wow, that's high. What about pregnancy? Is it common then?
Contact with chickenpox during pregnancy isn't unusual, but actually getting a primary infection catching it for the first time while pregnant, that's thankfully quite rare. Only about 3 in 1,000 pregnancies.
Ew.
Though there might be a slightly higher risk for women who grew up in tropical areas, possibly due to less childhood exposure there.
Interesting. Does the H people get it very much worldwide?
It does, actually. In
Yeah.
places like the US, UK, Japan, it's typically a younger childhood illness, often under 10.
Right.
But in other regions like India, Southeast Asia, the West Indies, it's often seen in older children, adolescents, or even young adults.
So it's not just a childhood disease everywhere.
Not exclusively, no. And the key point is you can get chickenpox at any age if you're not immune. It's found worldwide, it's endemic, meaning it's always around in the population.
Is there a particular season for it?
Historically, we'd see a peak in late winter and spring, maybe March to May,
Hmm.
though some evidence suggests that seasonality might be becoming less distinct recently, perhaps due to vaccination and changing population dynamics.
Okay. And remind us about the contagious period.
Crucial point. You're infectious for a couple of days before the rash even shows up, and you stay infectious until all the spots have crusted over, usually about 5-7 days after the rash starts.
Right, which makes it hard to contain sometimes. And just to be crystal clear, can you catch shingles from someone with chickenpox?
No, you can't catch shingles from chickenpox.
And can you catch chickenpox from someone with shingles?
It's possible, but much less likely than catching it from someone with chickenpox itself. The virus is present in the shingles blisters, so direct contact could theoretically transmit VZV to a non-immune person, causing them to develop chickenpox. But it's considered rare compared to chickenpox transmission.
Got it. Okay, let's get into the clinical picture. What does it actually look and feel like for the person going through it?
So, symptoms can sometimes be a bit more severe in older children and adults compared to young kids.
Okay.
Typically, it might start with a bit of a fever, feeling generally unwell malaise, maybe a headache, loss of appetite. Then comes the star of the show, the itchy rash.
Where does it usually start?
Often on the head or the trunk, the main part of the body. It starts as flat red spots, maculoles, then they become raised bumps, papules, and then they turn into those characteristic fluid-filled blisters, vesicles.
And they all happen at once.
That's the key thing. You see spots in different stages of development simultaneously. So over the next, say, 3 to 5 days, you'll see new spots appearing, while older ones are progressing from papules to vesicles, maybe becoming a bit pus-filled, pustules, and finally crusting over.
Right. And the distribution.
Mostly head, neck, and trunk. It's
Okay.
usually sparser on the limbs. You can even get them inside the mouth or other mucous membranes.
Ouch. And the itch?
Oh, the itch can be intense. Especially for younger children, it's often the most distressing symptom.
Does it scar?
It can, yes. Scarring is perhaps a bit more common or noticeable in adolescents and adults, and scratching definitely increases the risk of scarring and infection.
In fact, how would you spot that?
If you see significant redness, swelling, or pus around the lesions, that could suggest a secondary bacterial infection, often from Staphylococcus or Streptococcus bacteria introduced by scratching.
Okay. Any other specific presentations?
Well, in females, you can sometimes get lesions on the vulva, and if someone has a really prolonged eruption, like spots continuing to appear for weeks, that might point towards an issue with their cell-mediated immunity.
Right. And what about immunocompromised people? You mentioned they're high risk. How does it look different for them?
It can be much more severe. The lesions might persist for weeks instead of days. The vesicles themselves can be larger, sometimes even hemorrhagic, meaning they bleed.
Oh, wow.
And tragically, these individuals have a much higher risk of dangerous complications like pneumonia or disseminated intravascular coagulation, a serious blood clotting disorder.
It really highlights the difference immunity makes. Okay, we've got these visual descriptions. And you mentioned a memory tip for the rash spread.
Yeah, think centrifugal, starting in the center, trunk, and moving outwards towards the periphery, limbs.
Centrifugal. Got it. So, faced with this classic picture, how is the diagnosis usually made? Do you need tests?
For the vast majority of cases, no. The diagnosis is clinical. That characteristic rash with spots in various stages, often combined with the history of exposure or lack of immunity, is usually enough.
Pretty distinctive.
It is. But if the presentation is atypical, Or if confirmation is needed for some reason, perhaps in an immunocompromised patient or during pregnancy, then yes, lab tests can be done.
What kind of tests?
You can take a scraping from a fresh lesion and look for the virus using techniques like immunohistochemical staining, or more commonly now, use PCR tests to detect the viral DNA. PCR is very sensitive and specific.
Okay. And what if you suspect complications?
Then investigations depend on the suspected complication. If someone's got respiratory symptoms like coughing or shortness of breath, a chest x-ray would be important to look for pneumonia.
And neurological signs.
If there are concerns like severe headache, confusion, or seizures, then a lumbar puncture to analyze the cerebrospinal fluid might be necessary to check for encephalitis or meningitis.
Right. Targeted investigations for specific worries. So let's move on to management. Someone has chickenpox. What do we do?
Okay, management really focuses on two main areas: supportive care for everyone, and then specific antiviral treatments for those at higher risk or with complications.
Let's start with supportive care. What does that involve?
It's mostly about comfort and preventing problems. So keeping the person cool can help with the itch. Trim fingernails really short, especially in kids, to minimize skin damage from scratching.
Good tip.
Over-the-counter paracetamol can be used for fever or discomfort. Importantly, avoid aspirin in children due to the risk of Ray's syndrome. And there's some caution around NSAIDs like ibuprofen, as they might slightly increase the risk of severe bacterial skin infections. Paracetamol is generally preferred.
Okay, paracetamol for fever. What about the itch? Calamine lotion.
Calamine lotion used to be standard, but it's not really recommended routinely now. It can be quite drying and sometimes make itching worse once it dries. Soothing emollients or moisturizers are often better. Antihistamines, particularly sedating ones at night like chlorphenamine, can help with sleep and reduce itching.
Right. And isolation.
Absolutely. Keep the person away from school or work, and particularly away from high-risk individuals, pregnant women, newborns, immunocompromised people, until all the spots have crusted over. Good hand hygiene is also key.
Makes sense. So that's supportive care. What about specific treatments like antivirals?
Antiviral medication, usually acyclovir, isn't generally needed for otherwise healthy children with uncomplicated chickenpox.
But for whom would you consider it?
Definitely consider for high-risk groups. That includes immunocompromised individuals, people with severe underlying lung or skin disease, sometimes older adolescents and adults, especially smokers, as they have higher pneumonia risk, and newborns whose mothers develop chickenpox around the time of delivery. Also, if someone has really severe disease or develops complications like pneumonia or encephalitis, or if they're on high-dose steroids. And interestingly, sometimes it's considered if new lesions are still appearing after about day 7 or 8, or in the rare cases of rash following vaccination.
And how effective is it? Does it need to be started early?
Yes, ideally it should be started as early as possible, preferably within 24-72 hours of rash onset, to have the most benefit in reducing the severity and duration of illness. For immunocompromised patients, starting it promptly, whether oral or intravenous, can really shorten how long the vesicles last.
What about pregnant women who get severe chickenpox?
Prompt treatment with acyclovir is crucial for severe maternal varicella, even if they've received VZIG prophylaxis.
Okay, let's talk about VZIG. What about people who've been exposed but aren't immune?
Right, post-exposure prophylaxis. This is mainly for those high-risk individuals we mentioned, immunocompromised people, susceptible pregnant women, newborns exposed around delivery if they had a significant exposure.
And what do they get?
They can be given human varicella zoster immunoglobulin, or VZIG. This provides temporary passive immunity. It needs to be given ideally within 72 hours, but up to 10 days post-exposure might still offer some benefit.
Does it always prevent chickenpox?
Not always, but it can prevent infection or make it much milder if it does occur. If someone develops severe chickenpox despite getting VZIG, they should still be monitored closely and might need acyclovir treatment.
Okay. And what about babies exposed around birth?
Acyclovir might be considered for neonates whose mothers develop the rash shortly before or after delivery, as they are at high risk of severe neonatal varicella.
And any specific advice for pregnant or breastfeeding women?
Absolutely crucial. They get specialist advice if they're exposed or develop chickenpox. There's that small risk, less than 1%, of congenital varicella syndrome if infected in the first 20 weeks, which can cause serious problems for the baby.
So specialist input is key.
Essential. For diagnosis, assessing fetal risk, considering urgent antiviral treatment for the mother, managing potential complications, and advising on breastfeeding.
That's a comprehensive approach. You mentioned a memory tip for management.
Yeah, just a simple one. Support, comfort, fluids. Soothe, itch relief, separate. Isolate. Sometimes special antivirals for high risk.
Support, soothe, separate, sometimes special. Nice. Okay, what's the outlook then? What's the prognosis usually like?
The good news is, for most healthy people, especially children, the prognosis is excellent. It's typically self-limiting, clears up on its own in 1-2 weeks, usually without any major issues.
That's reassuring.
But, as we've stressed, for those high-risk groups, infants under 1, adolescents, adults, pregnant women, the immunocompromised, the risk of more severe disease and complications is definitely higher.
So most kids get mild disease, but we need to be vigilant with those other groups.
Exactly. And once you've had it, you generally get lifelong immunity to chickenpox itself.
So getting it twice is rare.
Very uncommon in healthy people. It's more likely that a second VZV episode would be shingles, or perhaps in very immunocompromised individuals, a recurrence might happen, but it's not the norm.
Okay, let's talk more about those complications. What are the main ones to watch out for?
By far the most common is secondary bacterial skin infection.
From the scratching.
Exactly. Scratching breaks the skin, letting bacteria like Staph aureus or Strep pyogenes get in. We mentioned avoiding NSAIDs might help reduce this risk slightly. It can range from just one infected spot to wider cellulitis. And rarely, invasive group A strep can cause really serious things like necrotizing fasciitis or toxic shock syndrome.
Scary. What else?
And pneumonia is a big one, especially in adults, smokers, pregnant women, and the immunocompromised. It's usually a viral pneumonia directly from VZV, happens a few days after the rash starts. Symptoms are chest pain, cough, wheezing, shortness of breath. It can be life-threatening.
Okay, pneumonia is serious. Any others?
Encephalitis, inflammation of the brain, is rare but very serious. It might involve the cerebellum, causing coordination problems. Symptoms include confusion, irritability, drowsiness, vomiting, severe headache, stiff neck, difficulty walking. It needs intensive care and sadly carries a mortality risk of about 5–10%.
Wow, that's severe.
Other rare but serious things include disseminated hemorrhagic chickenpox, where there's bleeding into the lesions and potentially elsewhere. Very rarely, things like arthritis, nephritis, kidney inflammation, or pancreatitis can occur.
And other neurological issues.
Yes. Besides encephalitis, you can sometimes see things like benign cerebellar ataxia, which is usually temporary coordination difficulty, especially kids. Also, myelitis, spinal cord inflammation, or vasculitis, inflammation of blood vessels in the brain. And other infections like osteomyelitis, bone infection, sepsis, or even just a common middle ear infection, choroiditis media, can sometimes complicate things.
Quite a list, ranging from common skin issues to some really severe, rare problems. Do you have a memory aid for these?
Yeah, trying to group them might help. Think bacterial skin, the common one, breathing bad, pneumonia, brain bother, encephalitis, bleeding badly, hemorrhagic, and body bits for the other rare ones like arthritis, nephritis.
Bacterial skin, breathing bad, brain bother, bleeding badly, body bits. Useful framework. Okay, so to wrap things up. Chickenpox. Highly contagious, usually a childhood illness caused by VZV, which can later cause shingles.
Right. Typically mild, but with potential for complications, especially in specific groups. Supportive care is key for most, antivirals for some.
And vaccination is obviously a major factor now in prevention. The key message seems to be, it's often mild, but recognize the high-risk groups and seek medical advice if you're concerned or if complications develop.
Precisely. And that leads to an interesting thought, doesn't it? With widespread vaccination changing the landscape of chickenpox, what are the long-term implications going to be? Not just for chickenpox itself, but also for the incidence and severity of shingles in the population decades down the line.
That's a really important question, something for us all to keep an eye on. Definitely food for thought.
Indeed.
And for everyone listening who wants to dive deeper or needs solid revision resources, don't forget to check out PassTheMSRA.com and the free resources at freesra.com.
Great resources for medical students and junior doctors.
Absolutely. Well, thank you for joining us on this deep dive into the spots and science of chickenpox.